This is Nursing Uncensored. I'm your host, Adrianne Benning, and I invite you to listen in on conversations I've had with real nurses about the crazy and wonderful lives we lead. This podcast is meant to create laughter in addition to serious discussion, and nothing is off limits. We're always honest, but we're not always safe for work. Please listen responsibly. Welcome to Nursing Uncensored. I am your host, Adrianne, and I am here again today with returning visitor, friend and coworker, Margo. Margo, hello.
Hi, Adrianne. Thanks for having me back.
Yeah, thanks for coming back. Let's just jump right in. Will you start? I know that we have a lot of new listeners coming in all the time, and so they may not have caught up on our episodes yet. So will you introduce yourself to our listeners, please?
Yeah, absolutely. So like Adrianne said, my name is Margo. I have been a nurse for 2 years now, almost 2 years, which blows my mind. For that entire 2 years, I've been working on our floor, a respiratory step-down unit at a level 1 trauma center. And I did my undergrad BSN and then got my license.
And here you are.
And here I am. And here I am.
So, yeah, and we've worked together for basically the duration of time that you've been on the unit. And we work opposite shifts, but we've worked together a little bit, like especially early.
Yeah, I was going to say, so I did my senior internship on our floor. That's how I kind of came to fall in love with it. And I did night shift then. So we did work a lot more closely then, but we still see each other all the time doing.
I did want to actually speak to that because it's really cool when you have students come on the unit and you like meet people and like you see like, oh, they're going to be like, they've got these qualities, and then you come back and you're a colleague. And there's actually another nurse or a nursing student who is on our unit that's actually about to start a job on our floor in February.
So excited for him.
And this person is also awesome. And so while not every kind of, senior internship turns into like a job, it can. And even if it doesn't turn into a job that you want, it's still nice to have a group of nurses being like, you should come work here because we really like you. You came in that way. And it's always funny because sometimes, students come and, then there's time that goes by where you like have to study for boards and pass your NCLEX and start the job. And there's like this period of time between when you're on our unit as a student and you come back like in your scrubs.
Gray scrubs.
And so it's always like, we kind of forget for a minute and then we see that person and we're like, oh, hey,
oh my gosh,
you have licensure now. Like, congratulations. So, that's pretty cool. And so in that kind of vein, we are going to talk about senior nursing preceptorship. Some people call it an externship, or
I've also heard it called a capstone before.
Yeah, your capstone. Basically, it's the period of time you're spending in your last semester or your last year, depending how your school runs it, and you're on the unit with a nurse, maybe a couple nurses, depending on how the schedules are made. But basically, like you become, as the precepting nurse, you become that student's person on the unit, and that student comes and follows you, spends many shifts with you. Like we're doing, my person has 175 hours to do with me. Your person has what? You said like 225?
225. Mm-hmm.
So we're going to be spending a lot of time.
We're going to get real close. Yeah.
So before we get into talking about how we're preparing, because this is a new role for both of us.
Mm-hmm.
And I've been a nurse 3.5 years. I have oriented 3 nurses that have like already passed boards and are starting their jobs, but I've never taken on a student before. And I wanted to feel really, really ready. So I'm finally there. So let's talk a little bit about, I want to hear about your experience because you did a 4-year program for nursing, and I did a 2-year program and then got a job and then did another 2-year program to finish my bachelor's. So maybe talk a little bit about clinicals as a whole in your program and then kind of zoom in on that final chapter.
Yeah. So my program, you had 6 clinical rotations spread out over 3 semesters, so 2 per semester. First semester, you were in simulation. So, you're working with your fellow nursing students, learning how to do head to toe assessments on them. And then that semester was the heaviest, like lecture wise. Second semester, the clinical rotations were a med surge rotation and a geriatric rotation. I did my med surge rotation first at the hospital that we currently work at, which was actually, it was really rough. It was really hard. That was 125 hours. So we would go for 2 8-hour shifts a week. And the floor that I worked on was kind of a catch-all med surg. They did bariatric surgery. They do solid organ transplants, so kidney and liver. They do a lot of GI stuff. And we were kind of talking about this just a little bit ago. I went home every week, like in tears. And like had to talk myself. I know. And like I had to talk myself out of going into the advisor and dropping nursing school every week.
You're like, I'm done.
It was really hard. And there was obviously a lot of reasons, leading up to it. My program didn't require a CNA or anything like that. I had no patient care experience. So literally my first clinical day was at a level 1 trauma center with the sickest of the sick in our state. It was 0 to 60 real quick. And, the nurses on the floor have 5 patients. They are running around, trying to get their stuff done. They didn't really have enough time to slow down and help me out. My clinical instructor, again, she's busy balancing 6 of us on the floor, doesn't necessarily have enough time to hold my hand through everything, which I needed a little bit of.
Yeah. I mean, when you've literally never stepped foot into patient care before, and now it's go do it. Here you go.
And it was such basic stuff. It was like NA cares. I did not know how to coordinate one set of vitals and a bath and 8 a.m. meds. I needed a little, I was a mess. Luckily, my Gero rotation saved me. My Gero rotation was 90 hours, 45 hours at a long-term care facility, so a nursing home. Mm-hmm. I really enjoyed that experience, much slower pace. I was able to kind of ask questions. I was able to, get to know some of the residents, really enjoyed my time. And then kind of in an acute setting, I went to not the hospital that we work at, but one in a town over, to a physical medicine and rehabilitation floor. Where there are a lot of post-stroke patients. So I would be kind of able to see immediately following an acute event, the care and management for geriatric patients.
Right. Where do these patients go when they're discharged from the inpatient unit? Yeah.
Yeah. Third semester was a psych rotation and a peds rotation. I did peds first. I was on a pediatric hematology and oncology floor.
Ooh, intense.
It was. So at this point, it was before the new children's hospital had opened up. Mm-hmm. So we were still in the main hospital. And that was kind of a refreshing. I had a preceptor who made it a point of being with us individually. She, she was always available to help us out. And peds is really where I felt like I was able to figure out how to do nursing in a level 1 trauma center. I was able to learn how to balance care for these super, super sick kiddos.
That sounds intimidating. That's my peds rotation was really quick. Man, that's scary to me.
And then that clinical also included 1 8-hour shift on labor delivery, 1 8-hour shift on postpartum, and 1 8-hour shift in the neonatal ICU.
Did you get to see any live births?
I got to go get a dad and bring him into the OR for a C-section. Nice. That was pretty cool. They're like, okay, go get dad and bring him in.
Come on back.
Yeah, we're ready for you.
Don't pass out.
That was pretty cool. And then my psych rotation, I freaking loved. And I don't know if I ever had this conversation with you.
I don't think so.
I really fell in love with psych. So I was on a mood and eating disorder unit. That was a 90-hour clinical. And actually, before I started my clinical, I had accepted a job as an NA on that floor to start after my clinical. So I was like, okay, this is great. I can kind of scope things out.
Cool. And you kind of will know where things are, and you already have a little knowledge.
Yeah. And I loved my psych rotation. I loved everything about it. I loved kind of how gray psych is. There's obviously some very hard no's, but there isn't always a definitive yes. You have to sit down with the patient. It's really a collaborative effort. So I like going into senior internship, I was like, I am for sure, like, I'm going to be a psych nurse. This is going to be great. I'm going to work on this floor. It's going to be awesome. But going into my fourth semester, I wasn't able to rotate my senior internship, which is what my program calls it, on a floor where I had done a previous rotation or on a floor where I worked. So I wouldn't have been able to do a rotation on my floor. The only other psych floor, or the only psych floor that was an option, was the med psych floor that we have. And I wasn't really interested in doing it on there. So I kind of decided, because med surg had been so hard, I was like, I'm a different person. I've, figured out how to coordinate everything. I owe it to myself to prove that I'm not choosing psych because I can't do med. I'm choosing psych because I love psych. So on a whim, I put down a bunch of just random med floors. I ended up doing an 8-hour shadow on our floor, and I moved our floor up to the top of my list because I was like, I can learn a lot up here. It would be awesome. And by my third shift with my preceptor, I was like, oh my gosh, this is where I need to start. So I did that senior internship on a respiratory intermediate care floor and palliative floor. Freaking fell in love with it. It was a 225-hour rotation. And then sorry, not to interrupt you, but I want to lay this out for people. 225 hours, when we're talking 12-hour shifts, that's what, like almost 19 shifts. Yeah. So with the way it worked out, you can't do I wasn't able to do half shifts with my preceptor. I had to do full shifts, and I couldn't come up short. So I had to go over.
Got it. Yeah.
Whereas if I'd been on a med floor where they did 12s and 8s, I probably could have just done an 8 and like one extra 8 or whatever.
Right. And we have to remind people that this is over the course of 4 months, 5 months, something like that. Or is it
16 weeks?
Yeah. So, I mean, right? And that's in addition to your going to class and live your life and sleep.
Yeah. And trying to balance. So for my program, you also do a public health rotation that your fourth semester, a 90-hour public health rotation. So it's in addition to those 90 hours that you're working on your public health project, and balancing the lectures and, life outside of nursing school.
Yeah, it can be a lot, especially when it's not just that you have to schedule these shifts. You have to schedule these shifts when your preceptor's working. So if your preceptor, if you have every Thursday free, but your preceptor doesn't work Thursdays, well,
yeah.
So, it's a lot.
Yeah, it is. Yeah, I would love to hear about your clinical rotations.
Oh, yeah. So I did, as people that listen might know, I did a 2-year program, got my ADN, took my NCLEX so that I could start working and then have money and tuition reimbursement to pay for the rest of my BSN, which I did as a 2-year program as well. So let's see if I remember, because I feel like that thing happened that they told me about where it's like peds and maternity is not my specialty, but what's the chemical that that you get after you give birth that makes you forget how horrible and awful it is? Is that I don't remember.
Whatever.
Yeah, but that happened to me where during nursing school, people were like, "Oh, it'll be fine. In a few years, you won't remember how horrible this was." And I was like, "Yes, I will. This is the worst thing ever." And now I'm like, "What did I do in clinicals?" What? So I do remember this. I remember that during my ADN program, we did clinicals every semester, and every semester it was a different setting and we couldn't repeat. And I think I was at 4 different hospitals and a bunch of different units. So I started in long-term care. That's where they started us out. So we started in actually the long-term care facility we were at did skilled nursing for rehab, people who are just trying to transition from hospital to home after I had a lady that had a bilateral knee replacement. So she was my first. Then after a couple weeks or shifts, I don't remember, then I went to the long-term care part, which was the nursing home part and followed a nurse as she like went about her day and did a bunch of shifts there. That was a lot of CNA stuff. And at that point, I had been a CNA for, I mean, my perspective is different than yours. I'd been a CNA for like a decade at this point, maybe a little under, because I think I clocked in 11 years total by the time I actually passed my NCLEX. But so that part I had down. And so those early days of clinicals were a little frustrating for me because I was like, I know how to do bedpans, guys. Like I know how to ambulate. Hold on, I feel a sneeze coming on.
Yeah, no worries.
But yeah, I was like, I know how to get a person out of bed. I know how to so that was a little frustrating for me, but it was nice to start to see how these nurses were like putting together all the 8,000 things they had to do for all 60 people they had in their hallway. So I learned very quickly that long-term care is not for me. And there are some people that love it and will do it forever. And thank God for them because we need them. After that, I went into acute care. And again, this is where like the fuzzy memory comes in. I was doing night and weekend program. So I had classes in the evenings. And in my head, I thought, oh, well, then I'll have evening clinicals. No, we did first shift clinicals every weekend. So I was working night shift and doing evening classes all week long, and then waking up at 5 o'clock in the morning on Saturday and Sunday to go to clinicals. So that was an added stress on me that maybe in hindsight wasn't ideal, but it was the way it was done. And if I had done day classes, which wasn't compatible for my schedule, I would have had to do evening clinicals. So it didn't really make sense to me why they made the evening program do day.
Yeah.
These are things that leadership needs to think about when they're designing their programs. But yeah, I moved into, I did the locked med psych unit in our hospital. I did a semester there. I did a semester on our straight up med surg unit. And I jokingly refer to that as my lap chole internship because I had literally like every week, I had a patient that was at a different stage. Like I had a patient that was pre-surgical, right out of the OR, someone who had been in the hospital for a while, and then I discharged. So it was a joke that like I was the resident expert on cholecystectomies, which for those of you that are still learning, that's a gallbladder removal. So I had a lot of that. And then I did 2 ortho rotations. And then my final semester, I actually had 2 different preceptors. So the first part, I was on a unit, which I'm not going to say because I don't want to identify the unit or the nurse, but this nurse was... maybe her style of teaching worked great for some people, but her and I weren't really a fit. And I had some frustrations, and she had some frustrations, not with me, but with my school and the way my school did things. And I felt like she took it out on me. Like, for example, my school doesn't give, and I don't know about other schools, but my school didn't give nursing students accessibility to pull narcotics or controlled substances out of the AccuDose. And so if I had to give a medication, the 2 choices were either she pulled it under her name and I scanned it under her name, which when you're working, or I would give all of the non-controlled substance medications, log out, and then she would have to log in and give the controlled substance. So it was like a huge kind of pain in the ass, but that's not my fault. So
no.
Anyway, midway through that time I spent with that preceptor, they also took on a brand new nurse that they were orienting. And I already felt like I wasn't getting the amount of instruction that I needed. So I respectfully went to, my clinical coordinator. And I was like, look, I'm not really getting the experience that I need. And I'd like something that's a little bit faster paced and someone who's a little more attentive. So they flipped me to a hospital that's not anywhere near where I live, which was a bummer, but I got an awesome preceptor who was really actively engaged in teaching me and giving me valuable feedback, both what I was doing really right and the stuff that I could improve. So it was an intense half a semester with that nurse, but that is what I credit with being able, because at night it was a neuro/oncology unit. And since I'm not a chemo nurse, I'm basically useless to those nurses. Like you can't, as a student, you can't give chemo. Like that's some dangerous shit. So basically I was like a neuro orientee then. And that was great because I worked neuro as a nursing assistant early on in my career. And so it was nice to see that side of it from a nursing perspective. So that was my senior internship. I really liked my nurse. There on my like last shift, she was like, do you need a reference letter? And I was like, that would be really awesome. Thinking that like she'd write one up, email it to me. She sat down and finished it before the shift was over and then handed it to me before I left. And I was like, damn girl, make it happen. So she was great. She's popped up before in my like people you may know on Facebook, but we're not really in the same age demographic. We wouldn't spend time outside. I don't really have anything to say to her. So I'm like, whatever, I don't need to connect on social media, but it was a good experience. Oh, and also in there, over the summer when I did my locked mental health unit, which was kind of scary. We'll have to talk about that some other time because I do want to talk to you about psych because as this saying goes in nursing, you're a psych nurse no matter where you work.
Where you are. Yeah.
But also that semester we did our peds and OB rotation. But because our school is not the primary four-year school in the area, we got like kind of the leftovers for clinical experiences. And so I had one 12-hour shift. Two 12-hour shifts on OB, 2 12-hour shifts on peds. But both of the units had critically low census, like to the point where they almost closed the units. And so like literally my whole OB rotation was taking care of like one postpartum mom, one postpartum or one newborn baby. So that was the whole thing. So I got to do like a heel stick and some hearing tests and like that was it. So yeah, that was my experience. And that, I know that I learned a lot, not just about how to be a new nurse, but I kind of learned that every preceptor has a little bit of a different style and that can really make a difference for the student, especially since, how do I want to frame it like this? Let's talk about some of our thoughts going into this because we've done this as a student. We know what this is like. We know what we liked. We know what we didn't. Let's talk about some of the things that we want to emulate as preceptors and things that we hope that we don't do because we didn't like them. You want to start us out?
Yeah.
Give us a couple of your like things that your preceptor did that like you, and let's talk senior. Let's like cut it down to like your senior preceptorship, the bulk of that. What were some things that your preceptor did that you really liked or helped you a lot?
I got a lot of really positive feedback from her. She was able to watch me grow throughout the course of our semester. So she was able to say, look, we're taking care of this like really delirious patient or this like patient in this like crazy pain crisis. Cause we did, my preceptor is a hospice and palliative certified nurse. So we did a lot of the hospice and palliative side of our unit. She was really able to be like, look, this crazy, pain crisis, we did this last week. You got this, like kind of give me the reins to control how our shift went, how we did things, which really helped me as I started, after I graduated and got my license. And as I was starting as a new nurse, it really helped me with like my confidence being like, okay, I've taken on a full assignment. I survived. I might not have my preceptor with me, but I have my coworkers. I have a support system. So, really gave me that confidence to take on a whole assignment.
Yeah. That's so important.
Yeah. And feel like you can come into any shift, not necessarily knowing like how it's going to go, but knowing that like you can handle it.
Yeah. And it's, we spend so much time as newbies that we spend so much time feeling like we don't know what we're doing and we don't know where things are, that those moments of like reinforcing what we're doing right are really important because you may do great assessments, but if your preceptor never says that to you, you may have all these thoughts like, oh, well, when I do my assessment, she just stands there silently. Like she doesn't give me any feedback. She doesn't smile. Like I remember our first, my clinical group before, like in our second or third semester, we had an instructor who on the first day, like, as most of us were leaving, like, we were crying because we thought we had just gotten like drill sergeant, don't smile, don't. And it was funny because we ended up really loving this clinical instructor by the end, but she just had this like first day, like, don't fuck around and you'll be fine kind of attitude. But initially we were like, oh my God, it'd be awful. And then we had pet names for her, and like she was silly and great by the end. But like it can be difficult when you have a preceptor that's giving you like no feedback. So or if you have a preceptor that's only telling you what you do wrong.
Negative. Yeah. I mean, of course you have to be able to take constructive criticism, but there, you don't have to take like
abuse. Yeah. And so as a preceptor, I think it's really important to make sure, well, first of all, I think it's important when, and we can get into this in just a little bit, but like starting out, you need to establish those boundaries, with your preceptor and with your student. Like if you like receiving feedback a certain way, like for example, I wouldn't want to get like all my feedback at the end of my shift. Like, well, here are all the things you did wrong. Here are all the things you did right. That feels overwhelming to me. And it's not really rooted to any experience, so it doesn't help me. I like being able to say, like, when we come out of a patient room, hey, so, what do you think went right in there? I like that feedback, not necessarily like at the bedside, because you don't want to be critiquing someone in front of your patient.
Exactly.
Or even you have to be careful in front of other coworkers as well, because you don't want to because you got to remember, these students, like they look up to us.
They don't need an audience.
No. So talk to that's one of the things I plan to do is talk to my student about, how do you like to receive feedback? How is it most effective to you? And that feedback needs to be both positive and negative. And, I think it's also important that, as a nurse, we are watching them give medications, which includes, needles and creams and pills and drawing blood and tube feedings and G tubes and all this. So like for safety's sake, if you're about to do something really wrong that's going to hurt that patient, I'm going to stop you right then and there.
Exactly.
But if it's just like you were a little awkward with bandaging up that foot, or like it was something that's like not harming the patient or making them have a negative experience, we don't have to talk about that right now. If you're about to inject subcutaneous air into their belly, which I almost did in clinical, and that was the only time my preceptor, she grabbed my hand and pulled it away from the patient. She was totally within rights. She wasn't aggressive about it. The patient was a little old lady. She didn't notice, but like I had forgot to push the air. It was like the first time I'd ever given a heparin shot, and I forgot to push the air out of the syringe. And I was literally about to be like, here's your air, right in. And so that was the time she grabbed my hand, and she didn't say anything. She didn't say, don't do, but she was like, what do you need to do? That's what she said. What do you need to do? And I was like, oh, and then I pushed the air out. So sometimes it's like intervene suddenly, but still you don't need to be like, what are you doing? Oh my God.
Yeah. It's like the place to ask about push rates, for meds is not when they're standing there, like next to the patient. It's in the med room while you've got the MAR up, you can click on micromedics and like look it up real quick and go over it and like draw it up and then go into the patient's room.
Yeah, because there's a couple of things here. One is that you don't want to make your patient feel unsafe. Yes, they're learning, but that doesn't mean that they're unsafe. They're with you. So I'm drinking coffee, so of course I'm like burping because I'm chugging this venti iced mocha. But yeah, you don't want to give your patients a sense that they're unsafe because you're there supervising, but you don't want to do it in a way that makes them think that like this, like, oh, do they know what they're doing? Well, yeah, but they're learning. So
because I have had those experiences where like I'm at the bedside, I'm prepping, and at the end of my med surge, my rotation, my nerves were so bad that I was like giving Tylenol and my clinical, Tylenol, and my hands were shaking so bad because my like clinical instructor, I could just like feel her eyes on me, and she's like, the patient's right there. She's like, why are you shaking?
Right. And you're like, because I'm a student and everything feels high stakes, and I'm tired and I'm sleep deprived and I'm hungry and I'm scared. And these things are all normal when you're a student. So it's our job to also recognize when our students look like they're about to pee their pants and say like, hey, okay.
Like, what's
going on? What do we need to do here? Because one of the things, so I did do a little research, just kind of watching videos on YouTube and like Google searches and looking at different nursing websites. But one of the things that this nurse practitioner brought up that's a really good point is that when you're with your clinical group on a unit, you have allies. You have people that you know, that you trust, that you feel comfortable with. When you're on a unit with your preceptor, you don't know any of these people. Like, you're a student, you feel like, at least I did, I felt like a burden. I felt like, please don't let me do anything stupid in front of this whole group of nurses. But as the nurse, you need to like bring them in, show them where the bathroom is, tell them who the good people are to go to if you have questions. Like, another thing that was really great about my preceptorship or any of my clinical rotations is when, even if my nurse didn't have like a procedure to go to or something, they said, hey, you know, Patty's going down to the cath lab with her patient. Do you want to do transport with her and see how that goes? And make sure it's cool with that nurse and that the school's okay with it. Because, like, for example, the school may not want me to let my student follow another nurse for the whole shift. But like, if somebody's about to start an IV on a difficult stick, I might be like, hey, go in and watch that nurse, or like, hey, go. And I loved those experiences as a student, because not only are you getting to see like everything you can, because once you're a nurse on the floor, you don't get time to watch that bronch. Like, I was lucky once I got to watch a bronch in my first year of nursing, but that was because I had already clocked out and I decided to stay and the doctor let me watch, which actually did happen on our unit. I spent the last July 31st of 2016, I spent watching a bronch on a patient that I've known for years. And the patient was like, yeah, stick around, see what's going down in there. So I was like, cool. But as a nursing student, you're in a unique position to like watch stuff and do stuff. So follow everybody you can, see everything you can. And I've been talking for a long time. So what are some other things that you found really helpful in your nursing preceptors, or your what the senior
internship is what, so another thing that kind of similar to what you just said, my preceptor, you know, if we had downtime, would be like, hey, does anyone have anything super cool for Margo to check out, like with their next turn? Or does anyone have like
any wounds we can look at?
Honestly, or like anything like interesting specific to our floor. You know, I'm trying to think of what that, you know, because
like we have a lot of chest tubes, or like epidurals, or like stuff that you don't see on everybody.
Yeah, which actually, remember thinking about it, I got like we took care of a fresh lung transplant with 4 chest tubes, and this patient still had their epidural. And as we were, you know, doing that stuff, like we would like pull up policy and procedure, and like we have in our staff break room, we have a big bin full of all the different kinds of trachs and stuff regarding trach care, and then a chest tube for educating new nurses to our floor and students. So after, you know, when we had downtime, we would go in. Like the first time I had a trach patient, we went in and pulled out all the different kinds of trachs and talked through why they would do a Jackson versus a Shiley, or this transplant that I had when I was a student. That was the first time I had a patient with a chest tube. So after we got all of our patients settled in and asleep, we went in and kind of went over, this is how it comes out of the box. This is how you get it set up. This is what our charting needs to look like. So really taking the time to not even so much treat me like a student, but kind of really treating me like she was orienting me to our floor.
Because these things these are valuable. Yeah,
they are. Yeah. Like regardless of whether my student ends up on a pulmonary floor in the future, like she's on a, you know, they're going to be on the pulmonary floor right now. Might as well take the opportunity to learn everything you can about
at least see it.
Yeah.
Because here's the thing, you may end up working on a unit somewhere that has nothing to do with what your senior internship is like. Sorry, I'm struggling with the terms. I want to call it like all different things. But even though you might be like, not interested in working in that specialty or like totally not into med surge, you're still learning to prioritize. You're learning how to learn on the fly. Because as a student, you have to like commit this shit to memory. You have to like know the patho. You have to like really internalize it. Once you're a nurse, like if I don't remember something, there's no one to grade me on it. I just have to look it up. So like if there's a med I don't know, I'm constantly on micromedics. I'm looking on all sorts of different websites for like pathophysiology. Like, oh, I haven't had a patient with this autoimmune disorder. Like I need to look it up. Like I used to have to look Guillain-Barré up a lot because I was always like, what's that one? And now that I've looked it up and I've taken enough patients, now those things are internalized to me. But they wouldn't have been if I just took care of those patients and never looked anything up because I was never creating those connections, you know? So I feel like as preceptors, not only are we teaching them like the material they need to know to be able to pass NCLEX and work on a floor, but also we're like teaching them how to learn on the fly and how to look stuff up. You have to, like, if you've never given blood before, yeah, you can get another nurse to come help you, but you're not guaranteed to have somebody at that bedside with you all the time. You need to know how to find your policies. You need to know how to identify which tubing is the right tubing. Like, how do I put all this together? And so that's a great thing to do is be like, hey, even though I know how to give blood, you as a student don't. So when we give this unit of blood, we're going to pull up the policy, print it out, whatever you're able to do on your unit, and go through that. Make sure your student understands why. So it's really nice when you can say like, this is why I'm doing this. And then your student kind of sees how the wheels are turning, how it's all working for you. So, so I think that for like my first, you've already had a couple of days with your students, right?
Yeah. So I've had 2 shifts with my senior internship student, but also it's not like my first time working with students. So like I said, my program, most of the clinicals are at the hospital where we work. And that first rotation, med surge, our floor takes those first semester students. So that's an 8-hour day shift. So I don't think you maybe have seen them.
I kind of interact with students during like bedside report and stuff, but otherwise.
But I've gotten to work with them over the past, if I've been there 2 years, that's what, like four semesters, maybe 3. No, this might be my 4th. So I've kind of worked with students from both sides of it. And it's kind of interesting just to see because, that first clinical they could very well be like me and never have had any patient contact before versus senior internship, which is more about making sure that they have the tools and the resources to take a whole patient assignment and think critically and organize a shift. I am really enjoying it so far. The 2 shifts that I've had with my senior internship student, she's great. And she definitely has a lot calmer of a head on her shoulders than I did. I was, even when like, it's only been in like the last year, I feel like where I've like really kind of zenned out.
Same girl, same.
Being at work.
It took me a year and a half, 2 years to not just be like, all the time. Oh my God, what's happening? I was like very, very scared during my entire senior internship. And like, she just took to it. Like she jumped in, she, did all of our meds with her, obviously. Our unit was in prime, how do I want to say it? Like showed up in its true colors for her. We had so it was a wild night. It was, like, you're gonna learn shit tonight, girl.
Our first day we had a prisoner, we had a vented trach, we had 2 very acute palliative patients where we were running, but basically taking care of our 2 med patients between running and hitting our PCAs like every 10 minutes.
You're like, grab my coattails and keep up, girl. Like, let's go. This is it.
I'm like, I hope you brought your running shoes because here we go. Luckily, we did have enough time to sit down, and not so much for the first semesters, but for senior internship, you show up and you have to, part of your first shift has to be a tour around the unit. So I kind of gave her the lowdown, showed her around. I introduced her to all the providers that I could see. I like went through the list of this is probably who we'll end up working with and pointing people out. And then you also come with this little like, this is kind of like what my clinical experiences have been like so far, my clinical experience here. This is what you can do to help me have a good clinical experience. Mm-hmm. This is things that you can do that would hinder like my learning, which was very, very helpful. And then we went over kind of I put together, I called it a little wish list for her of like the things that I'm hopeful that she will get to see.
What are some things? What were some things on your wish list?
So I wanted her to see a CFer and kind of go over, and we kind of talked because the whole Trikafta.
So for listeners, that's a cystic fibrosis patient. Yeah. Uh-huh.
Yeah. And so we ended up kind of talking about Trikafta and Symdeko. So we kind of went into it, but I want her to see, the care and coordination that goes into our CF population. I want her to look at their list of morning meds and go, oh my gosh, have her jaw hit the floor.
Because for those that don't notice or that don't know, cystic fibrosis is a genetic condition. It's an autosomal recessive trait.
Yeah.
So if you have two parents that have the trait, then you have CF. So it does lots of things to the body, but because we're respiratory flora and it primarily affects lungs, among other things, we see a lot of patients chronically, from the time they become adults and they start, they're done being seen in the pediatric hospital. World. They transfer over to the adult hospital, and then we help manage their care through adulthood, which many decades ago, these people with CF weren't living to adulthood. Mm-hmm. So we've made great strides. And now there are medications like Symdeko and Trikafta being the newest one, that some people are taking it and they're like, holy shit, my symptoms are changing within days and I'm getting better.
It's targeting the gene that is affecting the way their body makes sputum, essentially.
Mm-hmm. So they have this thick, sticky mucus in the lungs and digestive system. And
so because of just the nature of the disease, a cystic fibrosis patient's med list and the team that is involved in their care, it's very big, it's very involved, and it's overwhelming, especially for a lot of floats. So I want her to see that, and I want her to feel confident in tackling that. Kind of the same thing, I would love for her to work with one of our lung transplant patients. We did get to help with a walk for the fresh transplant that we have on our floor. So kind of got to see it. That patient had all their chest tubes out though, so it was not quite the walk, a fresh transplant walk, but we were kind of able to talk her through everything else when a patient comes straight to us from the cardiovascular ICU, what those walks look like.
When you're literally walking down the hall with a patient that's attached to like 9,000 things, and they're all sutured in.
Yeah. And, they're walking with the 4 chest tubes, all to suction. They've got the epidural, the PCA, the like 5,000 IV drips going, the NG tube.
Yep. Potentially a catheter. Like it all kind of depends. They can have multiple IV lines.
So it might not be realistic to do a fresh transplant. I don't know that we have anyone up on the board to be getting lungs that soon. Yeah. But ideally, at least
we never know. We never know when someone's going to get lungs. And so,
and then going over just all of the meds and like talking her through what we do when we're working someone up, what it looks like when they come in for the surgery. And then we went over a little bit like what the ideal stay for after the surgery looks like. And then, but I think it'll be more likely that we'll see someone who comes in, who's had the history of the transplant and just needs antibiotics or whatever, but we can still go over the post, like the TAC and, all that.
Yeah. Like the lab draws, the levels that we have to check. Like, And, you're also likely on our floor, you're also likely at some point to see some like med surge overflow. So you're going to get that random, like an abscess in their foot that comes up to our unit.
And then what else? I do want her to take care of the two palliative patients that we took care of, that neither of them were actively dying. I want her to take care of someone. She got to sit in on a goals of care and we kind of got to go over because the situation was one of the patients that we got they came on our first afternoon. We finally got the patient comfortable, and we come in the next morning and we have orders for 3 sets of blood cultures, a CT without contrast, like enough, like 20 mils of blood between the rest of it. We got to talk. We kind of got to go over like advocating for your patient and how goals of care is never just one sit down conversation. It's a work in progress with this family. And so she got to see 2 very psychosocially heavy patients. And then I did want her to have a ventitrach, which we already knocked out. So
there's so much. Even though we're a specialty unit, I don't think that all specialty units are a bad thing for students, especially when we're talking about students that maybe have a bit more aptitude than others. They like to learn on the fly. They're not afraid to get their hands in there and like help. I haven't met my student yet, but I have high hopes because I feel like we get a lot of really good students that come through on our unit. I think that because our unit is so intense, not that I think there are any nursing students out there that are incapable, but it is nice when you have someone who does have maybe a little bit of CNA experience, or at least they, did pretty well in their first few rounds of clinicals, because, and this is what I want to talk about too. We're going to talk about this a lot. We're going to have future episodes about this as we dig deeper into this process. But one of the things that makes me nervous is that really there's 2 things. One is that there's a positive side and a negative side to this. When you have a student, the positive side is you've got a buddy with you. You've got someone that can help you turn, help you ambulate, get those overdue meds in while you go into this room and do that. So like it's nice because you've got like a partner in crime that you can kind of like do things with. So you've got built-in help. And as they become more competent and you see them do better and better, you can, within the boundaries of their program, you can let them do more and more things on their own. You still have to be present and there for safety, but you don't have to be like standing right next to them every time they give a freaking Tylenol. So as time goes on, you do get to see them help more and more, and that's good for you. But also teaching, especially when you have a busy shift, you have a lot of patients, you have really sick patients, it can be really exhausting to be teaching and taking care of patients and taking care of your own needs. So you're making sure your meds are passed, your patients are safe, that your orders are being, if you need to page, you have to do all these things, but also you have this other person that may or may not know what the hell you're doing. So you have to say like, I'm doing this because of it. So you're doing a lot of talking, you're thinking about a lot of things. So for me, the part of my brain that wants to naturally be overwhelmed by everything is like, this is going to be a lot. And we all have those days where we come into work and we're like, I hope I get patients that sleep and I can just get my charting done. And then I can just sit quietly and like work on competency. Like we all have those days where we're like kind of checked out just because we're tired or whatever. So, and I get that with students too, because as a student, I was like, I would do anything to go to sleep right now. Like I would, I would be a skin donor if you'd let me just go take a nap afterward. Like, so I get it, but you still have to rise to that occasion. So even if you have a headache or you're hungry or you're cranky, the student needs you, and you can't just you can't be a bitch to your student because you're tired and hungry. Like this person is relying on you, and you volunteered to do that. Well, I assume I volunteered to do this. Maybe not every preceptor is volunteered. Right. But generally speaking, I hope that if you're precepting, that you're not God, I hate that. Yeah,
it's something that you want to do.
Yeah. So, and if it is something you want to do, speak up, because you're 2 years in, but think about how many hours of patient care that is. Like we think about that, we're like 2 years, that's not very much, like clinical just taking, but 2 years,
a whole lot.
And are you 90%, 100%?
I'm 90%.
Yeah.
I'm 90%.
So like you're there, like you're working all the time. So don't discount this. So I was afraid, like I said, I waited, now I'm at like 3.5 years because I didn't think I was prepared. And for me, I wasn't prepared. You get to a point where you're like, maybe I can do this. Try it.
Yeah. And that is a big thing. I knew that I wanted to take senior internship students during my senior internship program. I was like, I want to do for another nursing student what my preceptor is doing for me.
Yeah.
Giving me like this confidence, helping me expand my knowledge, letting me, helping me learn how to take, I wanted to do that for someone. And it really wasn't until like the last year, like maybe more like maybe the last 6 months, where we had like a couple medical emergencies happen, or like my patient was obviously starting to go downhill and I wasn't completely terrified. Where I felt like, okay, I've got this. I can handle this. I know what to do. So this semester was the first semester where I'm like, okay, I feel like I'm at the place where I can give a student the experience that my preceptor gave me.
Mm-hmm. And it's important that people like you, and I hope people like me, although I don't want to pat myself on the back.
No,
but we need people that want to teach. Thank you. We definitely need people that want to teach, that care about the experience that students are having, because every single one of us comes out terrified. It's like, what's that show, Naked and Afraid? I feel like that's what your first nursing year is like. You're like, I feel so exposed and I don't know what to do and things are beeping. So yeah, I think it's important that we not only give like that tough love and that like, pick your head up, get this done. Like, you can do this. Yes, they're going to yell at you. Maybe they're going to be grouchy.
It's gonna be,
you got this.
You got to do it. Yeah.
But then also, the other thing, and kind of one of the things I want to talk about as we kind of wrap up here, and then we're going to come back and we're going to do like a midway check-in.
Yeah.
But one of the other things is you've got to protect your student, because while you and I are welcoming, friendly, we want to pay it forward, we want to help build new good nurses, there are some nurses out there, let's not lie, okay, there are some people that are going to try to eat your nurse or your student. They're going to try to take advantage of them. Oh, hey, you want to go do a bed change? You can go do my bed change. Honey, we got our own bed changes. Like, there are going to be those nurses that want to like abuse. So make sure you're protecting your nurse, or I keep saying nurse, make sure you're protecting your student, that you're not throwing them out to the wolves. If you know you're there with, Cindy Lou Boohoo, and she's like a nightmare for students, don't leave your student alone in a room with her for an hour. Like, know what your student is going to benefit from and protect them from the things. Don't let them make mistakes. Don't let them don't be like, oh, well, they're going to look dumb in front of the student or in front of their patient, but they'll learn. Like, protect your student, give them a positive experience. I do not like learning by fire. So I'm not one of those people that's going to be like, sink or swim, honey. That's not encouraging learning. That's what breeds anxiety in nurses. That's why we get people like me that come out and you're like, oh my God, I'm going to fuck everything up. No, you're not. You just didn't have anybody to tell you that. So take those nurses. If you have the choice, bring them to lunch with you. Don't just be like, I'm going on break, peace, and leave them sitting on a unit. Introduce them to people. Get them to know the staff so that while they're there, they feel empowered to ask questions, ask if they can be a part of things. They also need to learn delegation. Delegation is really hard for students because they're so used to being told what to do that then delegating, or you're a new student or you're a new nurse and you're delegating to a CNA who's worked there for 20 years. And you're like, what business do I have telling you what to do? So you have to learn the dynamics of the unit and how it all works. Give them a good experience, make it worth it to them. This person, like we talked about at the beginning of the show, this person might come back and be like your work BFF someday. Or someday they might be your boss. Because the thing you never know in nursing is we all kind of start at the same place. But I've told many students, once you graduate from school, that's where your comparison ends. You're all going to take NCLEX at a different pace. You're all going to pass with a different number of questions. You're going to go into different specialties, have different strengths. Some of you are going to get your master's immediately. Some of you won't even get a bachelor's for another 5 years until the hospital makes you. Your comparison stops there. I, as a nurse who's been there 3.5 years, I have no trouble asking a nurse who's been there a year for help if I know, hey, you did this procedure recently. You have it fresher in your memory. Or, hey, you just took this exam. Maybe you remember. Once you're out on the floor, everybody's got different strengths and weaknesses, and you need to just utilize. So if your student needs blood draw experience and you suck at blood draws, hook them up with somebody who's going to give them some good tips. Give them an experience that you would want to have. So that's my soapbox.
Yeah, no.
What else? I know that you had like a list of goals. So why don't you, I'll shut up for a second, talk about some of your other wish list as we work our way out of here.
Yeah. I think the rest of my wish list was, I want her to see an admit. I want her to do a discharge to another unit. I want her to see a discharge from another unit, which we already did. And then a transfer to our unit, a transfer out, and then a discharge. Mm-hmm. And then I guess we'll just see what where the rest of our shifts take us.
Yeah. You should definitely bring her to a unit-based counsel. Well, I mean, that might not work because she might not, if you're on shift on a day that we have a unit-based counsel.
And I brought it up to her. I told her I'm on the pain committee. I try and come and bring updates to our unit-based counsel. Is that something you'd be interested in ever seeing? And so she said that she was game. So we're gonna hopefully she'll get to see a pain committee meeting and come to hopefully a couple UBCs. The
more exposure we have to these things as students, the more choices we have as nurses. Yeah. I was slow to join shared governance because I was like, that sounds intimidating and scary and I don't know what it is. But now I'm like, this is just how you learn. This is how you stay involved. Mm-hmm. So I'm very excited for the upcoming semester. I hope that I can put my money where my mouth is and give the student a good experience. And then also I hope that I have the strength and personal fortitude to also learn about myself and accept like the things that I struggle with as a teacher. Actually, there are two things that I know I struggle with, and nobody's going to be shocked by either one of them. One is that I talk a lot. And so I need to tell my student day one, here's the thing. I want you to know what I'm thinking and why I'm reasoning and what my process is. But if it gets to be a point where it's like overload, just be like, verbal diarrhea has reached its capacity. Because sometimes it's like, if you're exhausted and you're trying to learn 100,000 things, you're not going to retain any of it. So I need to make sure that I'm not just like glazing over my student because I'm like going through a checklist of shit that it has to be relevant. So I'm going to try to keep myself brief and to the point. And then the other thing that I struggle with is feeling that like imposter syndrome of like, I apologize too much. I give too many disclaimers. I have a hard time saying, okay, now you are going to do this. And that's not to say like I have to be an authoritarian, but sometimes I do the whole like, I don't know, how do you feel? Do you want to try it? Maybe. No, okay, you don't have to if you don't want to. No, I want to be able to be like, I know you're scared. You can do this. Let's try. So those are the two things, is like knowing when to shut up and knowing when to be like, you're doing this. I know you don't want to, but you're doing this.
We're gonna
be fine, and you're gonna be good at it.
Very excited for both of us, and I'm excited for both of our students.
I also know that I'll be checking in. You know, we're not in a vacuum. Nobody nurses in a vacuum. So we have other people around us that can help us make sure that we're getting our student the best experience. So if I'm unsure about something, I'm just going to be like, hey, Brad, how would you teach this?
That is one thing. Since I'm just straight days, I do feel kind of bad that my student's not going to get to see nights. Mm-hmm. So,
and my student's not going to get to see days. So
yeah,
maybe we should do an episode on day shift 101 for night shifters and night shift 101 for day shifters. On nights, we take tons of admissions because once that 5 o'clock hour hits, our nurse practitioners no longer like keep our beds for us, and we get like all the med overflow at night. But unless we send someone to ICU in the middle of the night, we're never going to discharge anybody. So there are like trade-offs days versus nights. But yeah, we'll just have to kind of tackle those as they come. So, wow, this is a lot. Okay. And we're probably going to have parts like 2, 3, maybe 4, like midway, like wrap up, and then maybe, like what's the word I'm looking for? Like a reflection on the experience. Yeah. So I always enjoy talking with you. Again, we don't get to do it as much because we're opposite shifts, but from one former student to another, I wish you well on this journey, and hopefully Friday will go well for me. That'll be my first day with my student.
Yeah.
And
I'll be there on Friday. So
all right.
I can't wait to see you guys on the floor.
I'll see you at change. All right, cool. Well, thank you everyone for listening. If you've made it this far, I hope you found some good tips or information to take with you on your journey. As always, I love to hear from you guys, so please talk to us down in the comments. Let us know what you think. Visit nursinguncensored.com for lots of content, blogs, vlogs, merch, episodes, all sorts of stuff. So, all right. Thanks, Margo. I hope you have a great rest of your day.
Yeah, you too, Adrianne. Thanks for having me.
Happy nursing, everybody. Here at Nursing Uncensored, we may be, well, uncensored, but we're not unfiltered. Protected health information has been changed and concealed to comply with HIPAA. The things we talk about are from years of experience with thousands of patients, things we've read, stories we've heard. If you think we're talking about you, we're not. Also, we're real nurses here to provide helpful and accurate information, but don't take anything we say as fact without doing your own research. Refer to your state's Board of Nursing, Practice Acts, and your institution's policies and procedures if you have questions about your practice. Lastly, our very strong opinions are ours alone and do not reflect those of our employers, educational, or professional institutions. Thanks for listening, and happy nursing, folks.